Hello and welcome to Keep Talking, a community dialogue about mental health. I'm Gay Maxwell and I'm the manager of the continuing education program at the Brattleboro Retreat. The Brattleboro Retreat is a behavioral health and addictions treatment hospital in southeastern Vermont. It boasts 180 years of service and serves children, adolescents, and adults. The Brattleboro Retreat provides care and courage when being human hurts. Today I have in our studio, and I'm welcoming you with great excitement, is Dr. Todd Kammerzelt, who is the psychiatrist and unit chief on the co-occurring inpatient floor at the retreat.
Correct. Hi, Gay.
Hi, nice to see you, and thank you so much for taking the time out to do this with me today.
Thank you. It's a delight to be here.
Oh, good. Thanks. Tell me, how did you, just briefly, how did you end up at the retreat? Where did you come from?
Well, so I grew up in Wisconsin, halfway between Milwaukee and Green Bay, a little town called Sheboygan. I grew up there, went through high school, and then moved away for college, studied abroad, spent some time outside the country, and lived in New York and Washington, D.C., and most recently I was back in Wisconsin for medical education and medical training. And in 2003 I joined the staff at the retreat, as you mentioned, the inpatient co-occurring disorders unit as the unit chief there. And my wife and daughter and I moved to beautiful New England, and it's just been a fantastic opportunity, and it's been professionally really nice to be able to be part of a team at the retreat and serve a population that is often stigmatized and marginalized.
I want to ask you a question right off the bat, because I will bet that there are people listening today who hear the phrase co-occurring disorder and they don't know what that means. Could you elaborate on that and explain what that means?
Sure. Yeah, co-occurring, or the other term that's often used, is called dual diagnosis. And what that refers to is people who struggle with mental health illness, mental disease, and substance use disorder. So oftentimes, some examples of how that shows up, people may struggle with depression and alcohol dependence, for example, or PTSD and opiate dependence, or cocaine abuse and anorexia nervosa. It's a addiction and mental health illness at the same time.
One of the things we wanted to talk a little bit about today is that stigmatization of mental health issues and substance misuse addictions. And one of the things that I've noticed watching film and television is that people with substance, or characters with substance abuse addictions, are portrayed as a type. There's a stereotype, really. And oftentimes they come across as they're derelicts, they're homeless, they have tons of contact with the police, they're school dropouts, unemployable, and they're terrible parents. And I think that does a disservice sometimes to our empathy skills with addiction. I just wondered if you'd speak to that stereotype.
Yeah. So often with stereotypes, as is the case, there's a grain of truth, or there's a kernel of information that seems to repeat itself or resonate in some way, and then it's taken to the extreme. And so the people that I work with at the retreat are folks who suffer from a disease. They suffer from a brain disease, and that's what addiction is. It has biological underpinnings. And what I mean by that is, if you look at brains of people who struggle with addiction, they look different on fMRI, PET scans. Different regions of the brain light up differently than in people who don't. So we can see there's something different going on in their brains, and that's the biological basis. You know, who they are. There are brothers, sisters, there are kids, their parents, grandparents, they're police officers, they're firefighters, they're store owners, they're restaurateurs, they're health professionals. It spans across socioeconomic strata. Addiction, mental illness doesn't respect geographic, ethnic, cultural boundaries. It affects all of us. And the things that you would characterize, the extreme negative consequences of untreated illness, are what often happens to people when they don't get treatment. So someone who has untreated addiction or chronic mental illness falls down often the socioeconomic ladder. It's not because they start at the bottom, although that is a risk factor in some cases. Their ongoing use or lack of treatment results in police contacts, loss of employment, loss of home, divorce, child protective services interactions. So all of the things that the stigma that we see of the illness is a result of kind of its chronic course playing out.
Can you give a couple of case examples, for instance, of people you've seen that fall completely outside that stereotype?
Yeah. So a lot of the folks that I mentioned initially, there's people in positions you wouldn't expect and that are functioning for a period of time, or maybe they were and they ceased to be able to function at their jobs. So in the past, I've worked with people, physicians, attorneys, judges, entrepreneurs, successful marketing executives, across, that's one echelon of the socioeconomic ladder, politicians, to other folks, teachers, folks who stay at home and care for family members, people who are chronically ill with medical conditions who develop addiction or have untreated mental illness. And so it's really, there's not a typical person who develops addiction. It can really strike anyone. And you can't walk down the street and see someone and say, that person has addictive disease. You can make some guesses, but oftentimes as not, you wouldn't be correct.
I see. Going along with our theme about myths and facts and so forth, I was just going to throw out a few ideas that I think are prevalent in our culture and have you speak to them as to whether there's any truth in it or whether there's a whole other story behind this.
Okay.
So, for instance, one phrase I see bandied about is people who get addicted to drugs have a weak moral character. What do you say to that?
I would say that's false. I would say there are risk factors that we all have and some of those can be modified over time and some of them can't. So we all have genetic predispositions, kind of certain characteristics or traits that we inherit that we have no control over. And so we're all kind of loaded genetically based on experiences from our ancestors, even beyond our parents. And so those are some risk factors that can't be modified. Things that can be modified don't necessarily relate to a person's character or their innate sense of who they are. There are some character types or personality disorders that put people at greater risk for developing addiction or mental illness, but it's not a choice, and so I would say that it's false.
Okay.
Yeah.
Well, you just answered my next question then, which was that people talk about drug addiction as a choice. It's not a disease.
Yeah.
But it sounds like the evidence and brain science must be making a huge contribution to this. It sounds very much like there's lots more evidence about it being a disease.
Yeah, neuroscience is really, it's come a long way, but as many questions as it begins to answer get raised about the next level of interaction in the brain. And it really does, it's exciting to see our ability to see differences on a very, very small level in different regions of the brain and how they're different, or they light up on these imaging studies in individuals who have addictive disease compared to those who don't, or who don't have it and then develop it later on. So, I often tell patients, if you have 10 people who go out and use a common substance is alcohol. People coming of age will often misuse or binge drink on occasion as they, we'll say they turn 21. And they use a substance inappropriately over a period of time. We'll say there's 10 of these friends who go out Thursday through Saturday. One or two of them over the course of their life is likely to develop a problem with alcohol. And by a problem, I mean meet criteria for a substance use disorder. Those two people didn't stand up at the outset and say, I'm going to become an alcoholic and have all of the consequences that come from alcoholism. But on average, one or two people in a group of 10 who go out and experiment are going to develop that disease.
I see.
And they don't do it by choice, because all 10 of them are the same, but they have different risk factors and predispositions.
Yes. Once an addict, always an addict?
Well, it's false, false, and false. And I say that really strongly because people can and do change. Recovery is intentional, and it takes vigilance, but it's absolutely possible, and it's even likely in a lot of cases. But the road is not smooth, it's not a linear trajectory, and oftentimes it's not predictable. And that's really frustrating.
Yes. Addicts are damaged goods. They have fried their brains, coming back to all those brain scans. Have they fried their brains?
So one of the things so this gets back to the Partnership for a Drug-Free America, I think in the 1980s, had the very dramatic
fried egg
frying pan with crisping oil, and they dropped the eggs in and said, this is your brain on drugs, as the egg kind of cooks away. Fortunately, that's not the case. There are a few drugs of abuse that do actually have destructive capacity on the brain, and if you looked at brain images of folks who use some substances over long periods of time, it looks almost as though their brain has been eaten away, and that doesn't get regenerated or restored.
And what drugs are those?
So crystal meth is one that has really profound toxic effects on the brain. Fortunately, one of the things that we've learned with neuroscience, that we used to think that you're born with a certain number of brain cells and then they just die off over time and the connections get lost, and our brain changes in a less robust way and kind of atrophies or gets smaller and weaker in its capacity to function. What we're learning is that by changing behaviors, we change connections in the brain. So just as people aren't born with addiction, it develops, and they may have risk factors that make it more or less likely. The brain gets changed, and over time, recovery and changing of behavior patterns can make different changes that don't reinforce those patterns of behavior. And essentially, the disease isn't cured, it's still, the high risk is there to reactivate it, but it's dormant, and people can begin living their lives again in a functional, normal, healthy capacity. And that's really exciting.
That is exciting. That's really good news. Kids who become addicts had lousy parenting.
False. And this is really, again, really critical for parents to understand, and it's really hard for parents to understand. While good parenting can be protective, parents don't cause addiction. Kids who use substances at a young age, and most of the folks that I see who come for inpatient services at the retreat started their first use of substances, whether it was tobacco, alcohol, marijuana, or other drugs, at a young age. And what that does is the brain is still developing until 19 to 23, 25 years old. It forms completely a little younger a little earlier in women, a little older in males. But the brain is developing, and it's creating connections, it's creating capacity and compartments for later use. When a kid uses drugs or alcohol in those important stages when the brain is still forming, it sets them up for risk of addictive disease later on in life. And so it's about risk. And so if you use at an earlier age, you're at greater risk over the course of your lifetime of developing a problem with drugs and alcohol, which is why there's this critical window. And if kids can make it to 19, 21 before they use any substance, I mean, a lifetime would be great, but if they can make it past these really formative, delicate years in which the brain is forming, they have a much lower likelihood of developing addictive disease later in life.
That's very interesting. So one of the things I wanted to ask you following up on that is you talk about certain risk factors. Can you just talk a little bit about what those might be?
Sure. Yeah. One of the risk factors that I see, and I work on as you mentioned, the co-occurring disorders inpatient unit, and we defined co-occurring to mean folks who struggle with mental illness as well as a substance use disorder. So the first part of that is untreated mental illness is a risk factor. So things like depression, bipolar disorder, anxiety disorder, panic attacks, PTSD, eating disorders, those are risk factors. ADHD, those people have a higher risk of developing a substance use disorder later in life if the condition's not treated. So those are some conditions that increase your risk. There is an interesting study that's come out of the Center for Alcohol and Substance Abuse Studies at Columbia University. They do a really robust research paper that comes out every couple of years and lists a lot of protective factors that decrease risk. And I haven't read it in a while, but one of them that comes to mind is kids having dinner with parents 5 or more nights a week. Now, inherently eating with your parent probably doesn't convey a lot of reduction in risk, but what it does mean is that the family's together as a unit. The kids aren't eating something in 2 minutes and then going off with friends and you don't know where they're going or what they're doing. That's hard to do in a life where there are many siblings, they're active, parents are working. I mean, that's hard to do, but it's been shown there's things like that a good, functional, cohesive family unit can convey some protection. Age of first use of a substance. And as I mentioned, the longer people can delay using, the greater protection or less risk they have for developing a disease later on. Certainly, peer pressure and peer supports can put people at greater risk for use. So depending on how well they are established and comfortable in their relationships, can either be a risk factor or it can be a protective factor.
I see. It's sad in a way because it sounds like when people are struggling with mental disorders and they try substances to fix them, probably because they feel afraid or ashamed to admit that they're experiencing a mental illness. And then they end up with a double whammy of being having a mental illness and then also then a substance misuse. I mean, it's so hard.
And it's often why it becomes self-perpetuating. So even if you can get some time clean and sober from the substance, the mental illness is still there, and that puts you at risk for relapse. Or if you have the depression addressed, but continue to use alcohol or whatever the substance is, you continue to be at risk of developing or redeveloping the depression. And so these things kind of chase each other and as a person spirals.
Yes. Another fact or fiction: addicts who relapse aren't trying hard enough.
False. So absolutely recovery is hard. It's very hard. And as I mentioned, it's not predictable that it's going to work when people want it to work, or when your family wants it to work, or your boss wants it to work. It's not a function where I can study for a test, and if I spend more time studying, I'm probably going to do better on the test. If I spend more time working on my recovery, I may have a greater chance of success, but it doesn't mean that the outcome is directly related to my effort. And that's kind of a nuanced concept, but I think it's really important, because when people don't succeed or they have a step back in their recovery, it often doesn't mean that they're not trying or that they don't want to recover. Again, this is a biological illness. You would never say to someone, you have diabetes and you're just not trying hard enough, that's why you still have diabetes. Or you have heart disease and you're just not willing the heart disease away hard enough.
Right.
That's how I look at it.
So in a way, it's a relief, because I think relapse can be, not only can be horrible because it's a relapse, but it can be this sense of shame that people experience afterwards. And if they can understand that this is a disease, it's likely to happen. It's hard to do. Yeah. I don't know how many times, if they've done studies about how many times people relapse before they actually, feel they're in recovery. Yeah. But I can imagine that if it would be a relief to have someone tell you that's part of this illness.
Yeah, and they do for some substances. So for quitting smoking, for example, there's been studies done. And I talk to people about recovery is practice. And by practicing recovery, you get stronger at it and you get better at it. For folks quitting nicotine dependence or smoking, they often take 8 to 11 attempts before it sticks and they're able to quit for some duration. Doesn't mean that they never smoke again, just as folks in recovery from alcohol, opiates, cocaine, other drugs of abuse may have a slip or a step back. It doesn't negate all of the distance they've come or the successes they've had.
Yes.
And that's hard because we're so black or white often in looking at it. You're either successful or you're not, and not every relapse is the same. It's not the same setback. And it doesn't mean you've erased the gains you've made, because you still had that time sober, you still achieved sobriety, and you've learned what worked, and you've experienced kind of what didn't work or what risk factors you got caught up in.
Right. Can you explain to me, one hears a lot about the gateway drugs, and I'm wondering what you think about that term, gateway drug, and whether it's at all useful or accurate.
So the gateway drug theory was an idea that if people started with less dangerous substances, that they would necessarily move on to more dangerous substances. So to give you some examples, young adults or kids who experimented with nicotine, alcohol, or marijuana who did that today are going to be tomorrow's IV heroin users, methamphetamine users, crack cocaine addicts. And that hasn't borne out. It hasn't borne out consistently. The research is mixed on that. And in some ideas that are put forward, the reasons for that is nicotine, alcohol, marijuana are more accessible to people earlier in their life. So it's rare that you see early teens or pre-teenagers using IV drugs, for example. The availability is not there. They don't kind of have access to it. And so I think the notion comes up, and it comes up often in today's conversations about states looking to legalize or to decriminalize marijuana, and what is that going to do? Or in the 80s, looking at drinking ages for alcohol. Do we raise it? Do we lower it? What is it gonna? What effect could that have on long-term substance use disorders and alcoholism? What I do think happens, though, is again, the earlier that someone uses substances while their brain is still forming, the higher risk they are later on for developing a substance use disorder, whether that be marijuana, alcohol, cocaine, heroin. There's something else about being in that culture of drug use that it becomes more available, because when it's underground, all of those substances become more available. And so if you start using alcohol surreptitiously at a younger age, you inherently are around folks who may be using other illicit substances as well, and the risk factors go up.
It sounds like there's so much that needs to go into, social support, behavioral, help, help with recovery. So many pieces to this in order to achieve recovery.
Yeah, absolutely. It is. It is a multifaceted approach to recovery. It's an illness that has devastating effects on families, employers as their employees struggle with addiction, tremendous effects in costs to the community. It's hundreds of billions of dollars a year lost in the economy, either to direct health care costs, disability costs, lost employment, people losing opportunities for wealth accumulation in the future because of incarceration, and then records that don't allow them to get loans or to get jobs or things like that. So yeah, it really requires multiple angles of approach to recover.
I see, yeah. You must deal with a wide range of age groups. Can you give an idea of what particular misuse happens on a developmental scale? I mean, can you explain it developmentally? I mean, teenagers are using different substances than, let's say, the elderly.
Sure. Yeah, and I think looking at those kind of two ends can be instructive. So we talked about the idea of gateway drugs based on what's available and what's not available. Early teens, preteens use very different substances than 40, 50, 60-year-olds. And for example, children, now I'm talking 11, 12, 13, 14, first start experimenting with inhalants. And by inhalants, I mean hydrocarbons, turpentine, paint thinner.
Is this what
blue,
is huffing?
Huffing, yeah, exactly. And they do that in part because that's what's available. These are common household items that parents don't think about their kids using or abusing to get high on or to have an altered state with. Incredibly dangerous. Huffing is incredibly dangerous. And I think the statistic that I read recently is about 6.5% of 8th graders across the country have tried huffing. Now 6% is about 1 in 16. If you have a class of 32, that's 2 kids. That's a lot. That's a frightening number. The good news is the number of kids who huff as you move into high school goes down, in part because they learn the dangers of huffing, whereas when you're younger you don't necessarily know the dangers. The other reality is they move on to other substances that become more available. So it's really rare to see a 13-year-old who uses IV drugs, fortunately, right? But they use other substances. They use chemicals in a bag or an aerosol can that they huff. Similarly, at the other spectrum, it's rare to see 60, 70, 80-year-olds using IV drugs. Right? So as folks age, they tend to be more at risk for misusing prescription drugs, prescription pain medications, benzodiazepines like Valium, lorazepam, Xanax, and alcohol. And the thought is they do that to address medical illness, physical pain, psychological stress, psychiatric, and a lot of loss. A lot of loss, yes. I am, we're about to run out of time, but before we end this, I do want to ask you to speak to families. What can families do to help loved ones? What shouldn't they do? What's out there for families? I think one of the things that is really important as a family member is to not blame yourself. You didn't cause the illness. You didn't make the person develop the illness. Whether it's a mental illness, whether it's addiction, it's not your fault. Okay. The other thing is to reach out for help. Now, whether that's with a coworker or colleague, an employee assistance program, if it's a friend and you're in school, to contact the counseling service or advisor at the program, reach out to a parent, contact your primary care physician, or call the retreat. And there's people who can work with you who have experience in these areas. So don't stay isolated is one really important message. There's other peer support recovery that's out there, and that's free. It's not run by clinicians or folks who are trained in mental health or addiction necessarily, but it's people who have experience and their peers.
One of those groups is Al-Anon, correct?
Is Al-Anon,
and there are lots of Al-Anon chapters throughout this state, but also in this community, lots of meetings.
Al-Anon, Nar-Anon, which is Narcotic Anonymous for families. There's Alateen for teenagers who have family members that struggle with alcohol problems. And then there's AA, Alcoholics Anonymous, NA, Narcotics Anonymous, CA, Cocaine Anonymous. And there's a number of kind of other anonymous groups that follow the 12-step or peer support recovery model that are really important supports that are available. And as I mentioned, they're free and they're ubiquitous. There's tens of thousands of these groups going on across the country.
And it's a really good way of not getting yourself isolated with this problem.
Exactly.
Because many people share it with you. Yeah.
The other thing that you can do to educate yourself, there's a couple of authors, there's many authors who have written about this. There's two that I would recommend. One author is David Sheff, and he's written a couple of books, Clean and Beautiful Boy, about his experience as a parent struggling to figure out how to best help his son who struggled with addiction along the way. The other author is William Cope Myers, who's written a couple of books. One of them is entitled Broken, and I'm blanking on the name of the other one. Now What is the name of that book. And that's a first-hand account of addiction and his struggles to maintain sobriety. And those are books that I would recommend. There's others out there. Some of them are good, some of them are less helpful, but there's a lot to choose from.
Great. Well, I want to thank you very, very much for spending your time with me today and answering all these questions and really helping, I'm sure, a lot of people out in the community understand addiction in a different way. And I just thank you for being with us today.
Yeah, thanks, Gil. It was a privilege to be here. Thank you.
And we're going to wrap up another episode of Keep Talking, community dialogue about mental health. I have to give a shout out to BCTV. They are our co-producer. They produce almost everything, really. But we really appreciate all their help, and I will look forward to seeing you again on our next episode.